for inviting me. I see a lot of friends on the dais there, and my most wonderful greetings to all. I'm going to share my screen. Um, can you see my screen right now?
Yes, it's visible.
Excellent, okay. And the slide is visible now?
Yeah, we can see it.
Excellent. So thank you to the IPDI 2022 for having me as a speaker. And I'm going to share my journey along the calcified course. I saw two brilliant cases done by Shivanan, and he's one of our wonderful operators from the East. And of course, I see that following me is Fazila, who's again an amazing operator, and I've heard her speak on calcified lesions. So I'm going to try and lay the stage in where the different devices play a role and how I use them in my cath lab. Um, if I kind of get anywhere close to, you need to call out and ask me to stop, please don't mind, because I don't want to kind of intrude on any other time. This is a great article to start with. It's beautifully written by Maria Giovanni. And I think what it talks about is our management of calcified coronary arteries has become a very, very methodical algorithm. And it talks about these two shades, which are the yellow and the purple or the lilac. And we're talking about areas which are the crossability and the dilatation of the lesion preparation part for the calcified lesion. And finally, once you put in a stent, optimization of the stent is an absolutely crucial item. The way I look at it, I modified this approach a little bit in my practice because of the availability of material and the kind of devices that I choose to use in my lab. And the most important question that I ask is this lesion crossable with an IVUS? And if this lesion is not crossable with the IVUS, then my next question is, would a microcatheter cross this? If the microcatheter crosses it, then of course rotational atherectomy, orbital atherectomy are two devices, because the microcatheter will assist you in putting in specialized wires with the rotor wire or the wiper wire for the orbital atherectomy. And if you have the microcatheter having difficulty, then you have two choices. One is a tornus, which we use in a 2.1 and a 2.6, and I'll show you a few cases. The other is ELCA, which we've had in our lab for the last 1 year now, and I'll share some of my experience with that as well. And even after this, once we've used a tornus and an ELCA, we may have to escalate to a rotational atherectomy or a balloon device to be able to get an imaging catheter in, and then go assess those images and then decide the lesion preparation finally. Because remember, the first part of the story in the calcium phase is only the access. So this is the access of the artery or the lesion, because it's uncrossable at many times. Here is a case, right coronary artery, totally occluded, calcified lesion. We had a wire across. We tried every little trick in our book, like Shivanand's first, like one of the other cases that I saw briefly. And eventually what we did was we used a tornus device, 2.6 French in this case, and we we gently screw it at 30 revolutions counterclockwise and then clockwise again. And when we do that, we kind of make a passage. In this particular case, you could see the passage was good enough for a balloon to go in, and balloon dilated, and we kind of crossed the lesion and completed the case. The tornus created a passage for the high pressure balloon to pass. It was a simple situation. When it gets a little more complex, as in this right coronary artery, there's tortuosity, the access is difficult because it's an awkwardly taking right coronary artery, and there's calcium right at the mouth, very difficult for guiding catheters to sit there. And you can see this subtotal occlusion right in the mid segment, which is heavily calcified. We used all our tricks in the book. A fine cross microcatheter could not. This is a Gaia 3, which has actually crossed it. And we could not get a fine cross to cross it. Once we then decided to have, this was a guiding catheter with a guidezilla support, with a tornus, and then a Gaia through that. So we used that tornus with a Gaia third. Over the Gaia third, we slipped the tornus in, changed it for a rotor wire, and then did a 1.5 rotational atherectomy. Believe you me, in these cases, sometimes you cannot align the guiding catheter to the right coronary ostium. And what I do in this is, to make it safe, I put the guiding catheter into the sinus, pointed the opposite side, and let my burr go in the aorta into the artery most coaxially. And this is probably the safer way to do it in these patients, or you end up having a burr jam at the ostium of the right coronary artery. So once we finished that, it was simple to kind of go ahead and complete the case. Sorry about these slide repetitions. The tornus allowed us passage of the rotawire and completion of the case. Now, sometimes the IVUS catheter does not go as in this case. I mean, this is a strongly significant FFR for this LAD. This is a patient who had an inferior wall MI many years ago, now unstable angina with a progression of disease in the LAD. But there's a calcified lesion at the front, which prevents any access into this artery. And so once you have, if the IVUS didn't go and if you've got a rotawire in, get a rotawire, and I often go up to 190 revolution, 190,000 to approximately 210,000 initially. I almost always now in the last 2 years follow it with 120 revolutions per 1,000 revolutions per minute, a couple of runs to make sure that it passes easily without any drop. Now, these are uncrossable lesions with the IVUS catheter. In 2022, one may have alternative approaches to this. Like one may say, why not use an NC balloon, dilate it, and just go with an IVL shockwave and make it simple? Why use a rota altogether? And I think I have a little bit of an issue with that, and I'll show you why. Here is a simple case which I thought was a very straightforward problem, unstable angina in an elderly man. If you look at his CT, the CT shows that he has a very small flake of calcium in that area. You can see there's only this one little area of calcium with a tight narrowing, which is a soft plaque with a dark plaque, the angiography corresponding. And when you look at this, this is what I have. And often enough, what we do is we see if we can get a 2.5 balloon in. And this was a tiring evening. And so I said, okay, let me just get a 2.5 balloon in. We got it in. We did have a little bit of maneuvering, and I should have taken a clue from that. But you can see that the 2.5 balloon is dilated very well. So I positioned, and this is where we did our OCT. This is what our OCT showed. You can see, concentrate on these images over here. You can see these images well. We had a cracked lesion there, but this central image is pivotal. You have a normal artery on one side. You have a huge protruding calcium mass on the other side, which is very significant and corroborates to the vision that we had in the CT. And we've got a very skewed up little lumen, which is almost eccentric. So this is where we needed to make choices. And I thought if my 2.5 balloon dilated this lesion at 8 atmospheres, then I thought I was going to be greedy and go ahead and put a direct balloon right there. We put in a stent right there. Laid it up at 12 atmospheres, then dilated it with using these high pressure dilatation balloons of 3.5 NC at 18. And what do we find on the OCT? We find that the MSA is just 4.55 in this one spot. Now, this is a problem. I mean, this is exactly where we had this calcium. I had all the reasons to have chosen a rotablator at this stage. My wire was favorably biased to it. It was an eccentric protruding calcium. But I just did not. On that particular day, I thought, okay, let me make myself a little easier evening. After this point, we actually went in with an IVL balloon of 3.5, gave it 80 pulses. But what did that do? It did not do anything. It just made it 4.71, and that's it. We still had a suboptimal result. So in these patients where protruding calcium of less than 180 degrees, which protrudes into the lumen in these large arteries, balloon dilatation strategy upfront in calcified lesions, you have to confirm a complete expansion of a 1:1 size balloon before placing a stent. I did not do that. Expansion of a smaller size balloon should not be considered as lesion preparation. I think that's the key statement. The balloon dilatation strategy upfront in a calcified lesion, if the post balloons larger, if you have a large protruding calcium, like we did in our case, which is less than 100 degrees arc, and if the wire bias is favorable, which it was in our case, then we should consider rotational atherectomy. If we don't have a favorable wire bias, this is still a problem in our cath lab, because when the wire bias is not favorable, we do not have orbital atherectomy, and we don't have any predictable technology to deal with this at this present time, other than very high pressure balloons. And when you use very high pressure balloons in these patients, you have to undersize the artery in these calcified lesions, which are eccentric. Otherwise, perforations are a very, very big problem. Since 2020, 50 IVL cases that we've done in our cath lab with various strategies. 6 cases were for protruding calcium, which had less than 180-degree calcium arc. 1 out of those 6 post DS, which I showed you to improve MSA, we had only a 50%. We had 50% of our patients had suboptimal expansion in this calcium, which is less than 100. And so even IVL doesn't work predictably in this group of patients, though it works in a few patients, but not in all. This was a rota regret, because even after IVL, you can see we didn't improve the MSA great at this one spot that we have. I hope my problem is he has a good chance of coming back, and when he comes back, I think we will use a rotational atherectomy and try to burn off that area which protrudes into the stent struts, and probably that might give him a great result. So I had 2 opportunities to correct it. One is some difficulty crossing. I should have taken that hint. 2, on OCT, I saw a chunk of calcium, which I ignored. And I think that is important. We don't see any fluoroscopic calcium in this patient. But even then, when we try to do a balloon dilatation, we take a 2.5 or 20 atmospheres, we see this ring. For me, that's a very low threshold to pull out my rotablator and then complete the job. So undilatable lesions, great thing, use a rotablator. In this 73-year-old patient, high calcium score, we do an FFR, which is highly positive. We have to do this. You can see that there are sheets of calcium all around in this patient. We did our normal balloon dilatation with an NC balloon. Because the lumen was good, the wire bias was not favorable, so rotablator is not a great choice. And the calcium was more than 100 degrees around, more than 180 degree arc. So the natural fallout was to take a 3.5 IVL at 40 pulses. We were able to fully expand it, and we realized that this is the calcium cracks that you can see in the calcium layers, which are great, and you can see one on the opposite side as well. And we are able to open these out with great MSAs and great long-term results with a single stent strategy across that long lesion. When you look at heavily calcified lesions like this, which have a large branch, like in this LAD, extremely calcified artery, and we put in a wire in, and we know we have resistance. We do a 1.5 rotablator burr, and we move it through it, and you can see that in this diagonal, in the mid segment, this burr took the longest time, and we had actually spent more than 5 minutes of rota time to get this across. I knew that this would be a very dense calcium. So what do we do after that? We actually, I've had a little bit of a mix-up of those slides here, but I'm going to correct it. Just one moment. Sorry about the Jamala, but if I get it, we'll show you that case again. Okay, let me just continue where I am. This is an LED CTO, total proximal CTO. You can see that it's totally occluded right over there, the missing segment. And here we had a laser, a UB3 wire, which is a very favorite wire of mine, with a microcatheter gone across, but the microcatheter would not go across the lesion, whatever I did. And I had a guide catheter backing out. I had a UB3 wire in, and diffuse disease downstream, so I couldn't get the wire down too much, or less I caused dissection. So what do we do in this case? We use an ELCA. We use a 0.9 ELCA, 80 fluency, 80 reps. And here you can see the ELCA catheter moving so gently through that lesion. And once that happens, it's very simple. It's an alternative for these uncrossable lesions. You go ahead and do an imaging. You see distal disease, which requires it's 18 millimeters long from landing zone to landing zone. The proximal is a landing zone, which is there right here. You can see the landing zones. You can measure the lengths of those stents that you require. And you quickly know that you'd have to extend your stent from the left main into the very calcified proximal LAD, and then extend it downstream. So we were going to look at this one better and closely. But our stent strategy would have been a phono stent going into the ostium of the LAD and a 3.5 extending beyond. And of course, in the distal would be a 2.518. So let's look at the proximal LAD a little better. You can see that the proximal LAD, when you start from the left main downstream, you can see sheets of calcium. The laser already has done a little bit of damage to this calcium sheet, but we had unexpanded. Can you see that it's unexpanded over here? So we used an IVL, and at 40 pulses, I think this opened up well. What happens with this is that you can see that the cracks get deeper, they get wider. You can see the cracks widening up and getting deeper. You can see new cracks happening in this lesion, and then you're able to open up this artery with the same strength strategy that I showed. And of course, the MSAs are matching. You can see 19.9 in the left main and 9.9, all corresponding to a 3.5 vessel, which is optimally dilated. Now, when the imaging catheter can go across, I think we go to the second part of the story. That's when you analyze the calcium. You look at the arc of the calcium, you look at the length of the calcium, you look at the thickness, you look at the protruding calcium, whether it's eccentric, you look at wire bias, and you look at calcium reverberations. And when you have all this, the strategy is to escalate your burr. Because if your wire bias is good, and if it is eccentric calcium protruding, I think escalate the burr size. Like I showed, I was going to show you in that LED case, which was heavily calcified. But if not, if you don't have any of this, then I think you can go to a 1:1 size NC balloon, look for final expansion. Sometimes you could use a scoring balloon. Even after you've escalated a burr, you still need to come to this strategy of using a 1.9. I'm going to show this a little better in some of my cases. And if you have an area of inexpansion, then you go to an IVL shockwave lithotripsy. So here are a few cases. An 83-year-old gentleman, unstable angina. You can see this nasty lesion in the LED, and you can see the corresponding calcium in the CT as well. You look at the OCT, and you know that when you quickly draw a line as to where the branch is, and you realize that the artery beyond that is around, there's 3 millimeters over here and 3.5 proximally. So you know the sizes of the stents that you need to achieve over there. So you take NC balloons of the corresponding sizes, and then see if you look for complete expansion. And if you do find an expansion, then in this case, we can use an IVL. But in this sheet of calcium, can you see it's all circular calcium? We used an NC balloon 3.30 in the distal segment here, and 3.5 for this proximal segment here. And at 16 atmospheres, you can see that there's complete expansion of the balloon. So with this kind of calcium, when in 2021, when we started with 2020, when we first got IVL shockwave balloon in our cath lab, every time we saw the circumferential calcium, we prompted us to just use an IVL shockwave in the first year. And this, I currently realize that a simple NC balloon at 16 to 18 atmospheres can achieve optimal expansion in very many of these concentric or more than 180-degree calcified lesions as well. And therefore, that's a lot of cost saving for a strategy. And I think that that has become my favorite strategy in the cath lab following that. And this year, we are more shy to get on to IVL shockwave immediately, but it's a great tool to have in the cath lab when we are in difficulty. And you can have a great expansion of those stents based on this strategy. Coming back to the
Kirti, I'm sorry to interrupt you. We'll have to wind up in 2 to 3 minutes.
I can wind up right now, so we can have some questions here. Let's go to the last slide, really. So, in calcified lesions, rotational atherectomy, 1.5 burr, an LCA 0.9, fiber sometimes. I mean, I can show you cases if you need to. A tornus, as I showed you, sometimes you go straight to an NC balloon. You then do a lesion layered preparation, upsize the burr. Sometimes you do that. Rotational atherectomy, even after LCA or tornus, you may need to do a rotoblader. And even after all this, I think the first thing you do is imaging. And once you image this, you find out from imaging what is the size of that destination lesion. Take a 1:1 NC balloon, and this is the default most important step, because this is the step which is going to let us know about optimal expansion in these areas. And once you do that, now you have tools to govern you beyond this, which is OPN, scoring, flextome, and the IVL shockwave. OPN balloon, I reserve this for the ISR group. I would have shown you a case like that. I do not use scoring balloons at all in my cath lab, but my favorite and the most all-time favorite is the Wolverine or the Flextome cutting balloon, which I almost invariably use in eccentric calcified lesions, post-rotoblader, osteal locations, as well as in ISRs. The shockwave I reserve for my calcified 108, more than 180 calcified lesions, which are non-relenting or not expanding, or ones which have opposing plates of calcium, which are not relenting. Thank you so much.